Hello everyone, my name is Katie, and today I'm going to be presenting with Emily, Lauren, Meredith, and Kyra on recent antibody treatments for Crohn's disease. First, we're going to talk about what Crohn's disease is and what causes it. So Crohn's disease, which is commonly referred to as inflammatory bowel disease, causes chronic inflammation of the gastrointestinal or GI tract. So this disease affects nearly 3 million people in the United States. It can impact people of any age, but it is most often diagnosed in people between the ages of 20 and 30. Crohn's is an autoimmune disease, and this just means that the immune system is incorrectly attacking healthy cells. Crohn's disease can affect any part of the digestive tract. 1/3 of cases have small bowel involvement, 20% of cases have colon involvement, and the majority, 50% of cases, involve both the small bowel and the colon. There is currently no cure for Crohn's disease, and patients experience relapse bouts at unpredictable times during their life, impacting their quality of life. The most common symptoms include abdominal pain, fistulas, lesions, all ranging in severity, and the disease can be debilitating. Now we're going to talk a bit about the pathophysiology of Crohn's disease. So currently, there's actually not that much known about what causes the disease. And while the exact causes of Crohn's disease are unknown, this makes it especially difficult to come up with effective therapeutics for this disease. There is evidence, however, that the disease results from inappropriate immune response in the bowel that can typically arise from environmental factors in a genetically compromised or susceptible person. And these environmental factors include drugs, toxins, infections, intestinal microbes, and bacteria. Researchers have identified over 100 genes as risk factors for Crohn's disease. Many of these factors, including infection, environment, and dietary habits, also impact the severity of the disease and the dysfunction that it causes of inflammatory pathways. So first, we're going to talk about what happens at the organ level before we break down the possible dysfunction of those inflammatory and immune pathways. When the inflammation first begins, as a response to one of the factors mentioned above, a lesion, which is just an area of damaged tissue, typically forms around an intestinal crypt. Now, an intestinal crypt is pictured here. You can see where it's labeled crypt, and it's a gland in between the villi of the intestinal epithelium, and the intestinal epithelium lines the small intestine and the colon as well. Once this inflammation of the intestinal epithelium begins, the lesions develop farther into granulomas, which is just another name for a larger area of inflammation. And this inflammation develops in all of the layers of the intestinal wall. So once the flare-up of inflammation ends, the inflamed regions, they begin to scar over. And this is actually a cyclical process that is an issue in Crohn's because the inflammation and scarring is what leads to things like bowel obstruction, fistulas, stricture formations. Stricture formation is just narrowing of the blood vessels, and some of these can require surgical intervention. So a lot of the worst symptoms of Crohn's disease is a result of the inflammation and scarring cycle that occurs in the intestinal tract. Now we're going to talk about the cellular and molecular pathways that are involved in the physiology of Crohn's disease. So the immune-mediated response that's exhibited in patients with Crohn's disease is characterized by several key components. These include increases in pro-inflammatory mediators, such as tumor necrosis factor, and several interleukin or IL molecules. These molecules are important for the inflammatory response as well as the immune system response. Some studies have shown that Crohn's disease results mainly from originally the inflammation of T lymphocytes. And T lymphocytes are responsible for secreting these pro-inflammatory cytokines as well as tumor necrosis factor. So it's thought that the inflammation related to T lymphocytes is what causes these increases. Because of the proposed pathophysiology, many therapeutics for Crohn's disease target these key molecules that are involved, namely tumor necrosis factor and several of the cytokines involved. And we're going to be talking more in depth about these therapeutics. One prevailing hypothesis is that overactivation of the immune response to any number of the factors we talked about earlier begins the pathological appearance of Crohn's, and then the downstream consequences of this chronic inflammation worsen symptoms over time, and they continue and perpetuate the overactive immune response. For example, a number of studies have shown that the permeability of the intestinal mucosa in the GI tract is increased in patients with Crohn's disease. Alterations in this mucus barrier are thought to lead to stressing the bowels to be able to degrade and remove exogenous materials. But because the pathophysiology is not well understood, there are many theories and disputes regarding how to treat Crohn's disease and whether it is actually even an autoimmune disease. We do know, however, that the current treatments, including immunosuppressants, seem to be effective at treating Crohn's. Now we're going to go ahead and talk about several of the recent advances in treatments for Crohn's disease.
Human tumor necrosis factor is a member of a large family of proteins and receptors that are involved in immune regulation. The secreted form of TNF is a non-glycosylated protein that is produced by monocytes, macrophages, and T lymphocytes. Various stimuli result in its release, including bacteria, viruses, and immune complexes. TNF is a highly pro-inflammatory cytokine that is involved in many parts of the body, including the induction of fever, insulin resistance, and bone resorption, to name a few. It reacts with two distinct receptors, one that is expressed on all nucleated cells and one that is expressed on endothelial and hematopoietic cells, where they exert their effects. Said effects are pro-inflammatory in nature and occur through increased production of pro-inflammatory cytokines. TNF is involved in many key processes in inflammation, such as the activation of coagulation and fibrinolytic responses. This makes it a key player in Crohn's disease. The cause of Crohn's disease is thought to be from a mixture of environmental triggers, dysbiosis, aberrant immune responses / immunoregulation, and genetic susceptibility. Crohn's disease results in mucosal injury and inflammation where the epithelial barrier is breached as a primary or secondary event, and the luminal microflora stimulates a pro-inflammatory immune response. As Crohn's disease is associated with a T-cell mediated response, increased secretion of TNF from the lamina propria mononuclear cells had been found in the intestinal mucosa, and TNF-positive cells had been found deeper in the lamina propria and in the submucosa. Studies have shown that TNF is an early potent pro-inflammatory cytokine in the inflammatory process underlying Crohn's disease, and has been demonstrated in vitro to be involved in the pathological processes seen in Crohn's disease.
We will now discuss some anti-TNF treatments of Crohn's disease. The three drugs we will discuss are infliximab, adalimumab, and certolizumab. Each of these drugs will be looked at in detail. First, we will talk about infliximab. Infliximab is a chimeric immunoglobulin IgG1 anti-TNF agent and was genetically engineered. It is a combination of mouse and human antibody. It has been used in the treatment of inflammatory bowel disease. Infliximab works because it can fix complement and lyse cells which express TNF-alpha, which is membrane-bound. It also works to cause the downregulation of the inflammatory mechanisms in the mucosal mechanism. Infliximab can inhibit many of the biological functions of TNF-alpha, likely due to its ability to block TNF-alpha's interaction with its receptors. Infliximab is administered by IV and needs to be administered every 8 weeks. It first requires an initial 3-dose induction. Infliximab has been evaluated in 2 important studies that we will discuss, ACCENT 1 and 2. These studies looked at both the luminal and fistulizing phenotypes of Crohn's disease. For the luminal phenotype, it was found that there was higher likelihood in short and long-term remission and discontinuation of corticosteroids. For the fistulizing phenotype, infliximab helped close draining fistulas. About a third of patients on maintenance therapy were still in remission after 1 year. However, remission does not necessarily mean that patients have deep tissue healing. Next, we will discuss adalimumab. Adalimumab is a fully human immunoglobulin G1 Ig1 monoclonal antibody. Like infliximab, it also fixes complement and lyses cells that express TNF-alpha. Adalimumab is administered subcutaneously, meaning under the skin, via an autoinjector pen, and is given every 2 weeks. Many trials have demonstrated that adalimumab is effective for Crohn's disease. It has been shown to cause maintenance of clinical remission and the ability to heal draining perianal fistulas. The effectiveness of adalimumab has also been investigated in patients who have experienced loss of response or intolerance to treatment with infliximab. It was found that adalimumab was effective at inducing clinical remission at week 4 in this study. Patients who receive adalimumab are also more likely to experience mucosal healing. Now we will investigate certolizumab. Certolizumab is a chimeric humanized antibody fragment. It works against soluble, also known as secreted, TNF and transmembrane TNF. Unlike infliximab and adalimumab, certolizumab does not have the crystal fragment region that is typical in antibodies. It also does not fix complement or lyse cells as infliximab and adalimumab do. Certolizumab is thought to have higher binding affinity for TNF than adalimumab or infliximab do. Like adalimumab, certolizumab is administered subcutaneously, but certolizumab only needs to be given every 4 weeks, as it has a longer half-life. The PRECISE 1 and 2 studies enrolled patients with moderate to severe Crohn's disease. PRECISE 1 did not find difference in remission for patients who received certolizumab versus those who received placebo. PRECISE 2 found that when patients had a positive response to induction, patients on certolizumab had a significantly higher response and remission rate. While there are no trials comparing infliximab, adalimumab, and certolizumab, it is thought that infliximab and adalimumab are better than certolizumab for inducing remission. We will now spend some time discussing the pharmacokinetics of the 3 drugs we have talked about. Because infliximab is administered with an IV, large volumes of it can be used, and peak serum concentration is reached quickly after the drug is given. It also has low variability in bioavailability. Adalimumab and certolizumab are injected subcutaneously, which means they have a higher variability in bioavailability, meaning they need to be given more often. Subcutaneous injection is also more likely to create an immunogenic response. However, subcutaneous injection is a more convenient mode of administration than IV. The distribution of the 3 drugs discussed occurs mainly in the extracellular fluid. This happens due to cellular movement from circulation to tissue, by diffusion, or by receptor-mediated endocytosis. Distribution for adalimumab and certolizumab, the subcutaneously injected drugs, can be slower because it happens because of the lymphatic drainage and paracellular movement leading to assimilation into the vasculature. It is thought that metabolism and clearance of the drugs occurs through a variety of processes, including degradation and lysozymes after the formation of the immune complex, and catabolism by phagocytic cells. The clearance rates of the drugs discussed can be changed by concomitant medication and disease state. The 3 drugs discussed all have different half-lives, with infliximab being 8 to 10 days, adalimumab being 10 to 20 days, and certolizumab being 14 days. We will now discuss some of the problems associated with anti-TNF treatments. First, it is difficult to predict how successful one of the drugs we have talked about will be for a patient, and at what dose it will be successful, when compared to non-biologic therapies. As high as 30% of patients do not respond to anti-TNF treatments, and of the ones who do respond to it, almost half lose clinical benefits within the first year and then require a higher dose or a new treatment. This is called secondary loss of response. There have been multiple studies showing success and benefits for patients when they switch anti-TNF treatments after loss of response, but the short-term remission rates were not exceptional. The reason for initial lack of response and loss of response in patients is most likely due to factors related to metabolism of the drug or to anti-drug antibodies being developed. Another problem associated with anti-TNF treatments is related to the withdrawal of the drug. It is unclear whether it is possible for a patient to stop taking the drug once remission is achieved. The STORY trial, which involved Crohn's disease patients who were in stable remission from a combination of infliximab and immunosuppressors, found that relapse occurred after a median of 16.4 months. This trial only involved patients with the luminal disease phenotype. More research in this area is still needed. There are also adverse effects associated with the anti-TNF treatments discussed. Some patients have reactions to infliximab, more commonly 1 to 2 hours after infusion. This can involve itching, flushing, breathlessness, chest pains, hypertension, and headaches. Less commonly, patients experience a delayed reaction 1 to 14 days after infusion, and the symptoms of this are usually headaches, fever, fatigue, rash, myalgia, and arthralgia. For adalimumab and certolizumab, injection site reactions can occur. Because anti-TNF treatments cause patients to be immunocompromised and are often taken in combination with other immunosuppressants, patient susceptibility to infection is also a concern. Anti-TNF treatments may also be linked to malignancy because of the suppression of TNF. Rheumatoid arthritis patients taking an infliximab and adalimumab treatment had a threefold increase of malignancy according to one study, but this has not been confirmed in Crohn's disease patients. To wrap up anti-TNF treatments, it's important to note that they have led to improved rate of response and remission in patients.
Alright, so next we're going to go into a molecular targeted therapy of the interleukins to help aid Crohn's disease. So in Crohn's disease, there's 2 interleukin heterodimers that are involved in triggering the inflammation response you see in Crohn's. And these are IL-12 and IL-23. So each of these interleukins induces T helper cell differentiation, where IL-12 induces T helper cell 1 and IL-23 induces T helper cell 17. And these T helper cells are what kind of begin that cascade of inflammation you see in many different models of intestinal inflammation. So IL-12 has 2 subunits, P40 and P35, while IL-23 has subunits PL19 and PL40. So because these interleukins share a common subunit, which is the P40, as you can see from the arrows, researchers were able to use a molecularly targeted therapy to target just that P40 molecule. And what this does, it suppresses both the Th1 and the Th17 differentiation, so it stops the inflammation cascade. And molecular targeted therapy is just a therapy that targets a specific molecule to either control or change its overall function. So the drug they developed is known as ustekinumab, which is an anti-interleukin 12/23, and it's commercially sold under the branded name Stelara. So Stelara is a human monoclonal antibody. So this means that its synthesized antibody was originally derived from a human white blood cell. And this treatment is commonly given to the patients which the conventional and favored anti-TNF antagonist treatments were ineffective at treating their symptoms, or in some cases, patients experience undesirable side effects from the anti-TNF, so they chose Stelara instead. So it's really typically offered as a backup option instead of a first option to treat Crohn's. Stelara is also used to treat ulcerative colitis. If that typical treatment isn't working for the patient, This is also an inflammatory bowel disease similar to Crohn's. And in some cases, it's also given to children with severe and persistent plaque psoriasis. This is an autoimmune disorder which affects the skin surface. So the mechanisms behind ustekinumab or Stelara are actually pretty simple. It basically works by interrupting the inflammatory response cascade, which is implicated in the symptoms of Crohn's disease. So when the drug is first administered, the antibody works by binding directly to that P40 subunit that we talked about how both of the interleukins 12 and 23 share. It's that gray subunit that both of them have. And then this causes a conformational change in these proteins. So this change in protein shape actually blocks the interleukins from binding to either of their given IL receptors on the Th1 and Th17 cells. And because the T cells initiate the inflammation cascade by disrupting or blocking the interaction between the interleukin and the Th cell receptors, there's no inflammation cascade to be activated. So it's really important to notice that this one drug can bind to two different interleukins because of their shared P40 subunit, whereas if they didn't have a common subunit, you would need two different antibody drugs to bind to IL-12 and IL-23 independently, and then it would stop this inflammation cascade. But because they have this shared P40, we can use just one antibody to bind and have that conformational change in proteins to block the inflammation cascade. So lastly, we're going to go into the pharmacokinetics of the Stelara treatment. So treatment using Stelara begins with a single intravenous infusion, and this is based on the patient's weight. So this dose can range anywhere from 260 milligrams to 520. And because an IV is needed to administer this dose directly into the patient's bloodstream, it has to be done in a clinical setting like a hospital and by a trained professional. So this first dose is very high concentration and administered directly into the bloodstream because it's going to initiate the immediate response and reduction in symptoms, and it better introduces the new antibody throughout the body. So after the first dose and improvement is seen, this treatment is to be maintained every 8 weeks with a 90 milligram dose by subcutaneous infusion. So this means that the medication is injected into the patient's skin using a much smaller gauge needle. So this smaller dose and a subcutaneous infusion leads to a much slower absorption of the drug within the body. It takes about 24 hours for the drug to be fully dissolved and absorbed throughout the body. And because of this, it has about a 52% bioavailability administered this way. So sticking to a strict scheduled maintenance dose is key to seeing continued improvement of the symptoms implicated in Crohn's. And because of a simpler and safer means of administration by this subcutaneous infusion, it leaves the patient the option to administer treatment on their own time, so like in their own home or by a spouse or family member. But they also do have the option to see a healthcare provider or come to see a doctor if they want to have their maintenance treatments done in a clinical setting. In terms of excretion of this drug, it has a half-life of about 19 days. So this means it takes about 19 days for about half of the drug administered to be excreted from the body. And this is a very long half-life. For instance, something like ibuprofen, it only has a half-life of about 2 hours. So this drug stays in your body for quite a long time, which is pretty ideal for patients who are struggling with Crohn's disease and may not want to take medication frequently to treat it.
The next treatment is very similar to the Stelara treatment mentioned before. Brazikumab is an anti-IL-23 treatment using human monoclonal antibodies. This treatment only blocks the IL-23 immune signal and not the IL-12 signal, researchers have determined that the IL-23 receptor plays a larger role in causing inflammation than IL-12, so targeting just the P19 subunit of IL-23 may produce similar results to a treatment that targets P40. Just like the Stelara treatment, this treatment is intended to be used as a backup when TNF treatments do not work or cause detrimental side effects. This treatment is still under clinical trial, but is so far proving to be an effective treatment for Crohn's disease and other inflammatory bowel diseases. The mechanism for brazikumab treatment is also similar to that of the Stelara treatment, which you can also see in the diagram here. The brazikumab binds to the P19 subunit of IL-23, which causes a conformational change in the protein. From there, the interleukin cannot bind to the IL-23 receptor, which in turn prevents the site from being activated. Since the site is not activated, it does not cause inflammation. The pharmacokinetics of the clinical trial are slightly different from the previous treatment. The initial doses of brazikumab provided in a double-blind trial are 700 milligrams. These doses are given 3 times each 4 weeks apart through intravenous infusions. Following the 3 initial doses, patients receive 210 milligram subcutaneous infusions each 4 weeks apart. Even though a subcutaneous infusion is safe enough to take place out of a medical setting, patients were required to receive all doses from medical professionals during the trials. With further development, brazikumab could be the next approved treatment for Crohn's disease. Thank you all for listening.